Hello. Hello, hello. How you doing today, Jen?
Good. How are you? It's nice to see you, Chris.
Yes. I totally forgot to ask you. Is it Jen, Dr. Jen, Jennifer, Dr. Siegel? What do you like?
Anything's good. Yeah, Jen's good. Yeah.
Okay. I
Yeah.
I always forget to ask because I have like the names that I talk to you guys like offline about, and then I'm like,
Mhm.
oh yeah, I need to make sure I know what people like publicly. So I always want to make sure I'm saying the right thing. I always love your background. Is
Oh,
it
thank you.
wallpaper?
Yeah, it's wallpaper.
Oh, my good friend Allegra Castens.
hmm
She's incredible, throws down in her place, and she has like this beautiful wallpaper in her what do you call it, in her office. And then I think she painted her, yeah, she painted her living room, but she found some beautiful wallpaper, but it looks so regal. I love it. I'm like,
Thank
bestie, I
you.
love it, but yours
Yeah.
looks so good too. I'm like, I need to do. Well, actually, I live in a place where I can't really do much, which sucks. You rent a place and they don't let you do much. So
Yeah.
it is what it is. Well, welcome everybody that has jumped on. We're about to get started. A couple of quick announcements before we jump in. So, first and foremost, it's so good to see you. Every Wednesday, we're here. It's Ask the Experts, where I always bring on someone to join me. They're here to give you education, information, answer questions, give you direction. I know there's so many people out there that unfortunately do not have a lot of resources, can't find a therapist on waiting lists. And so we hope these live streams give you community and give you an opportunity and a chance just to kind of, I think, hold over during the week. I know for me personally, in my OCD recovery, there was a support group I was part of online because I couldn't leave the house to go to one in person. And so at first, then I ended up getting better enough to go to an in-person support group. But I just remember that holding me over for the week. So we're so happy you're here. Every first Wednesday of the month, it's myself and Dr. Liz McInvale. Every second Wednesday of the month at 12 Eastern, I have a psychiatrist come on to answer medication and oh, I hate that word, pharmacological questions. And we'll talk about our guest today. Every third Wednesday, I have myself and, of course, Kimberly Quinlan. And then the last, either fourth or fifth Wednesday of the month at 12 Eastern, I have different guests, different experts from all over the globe. So it's always excited to have people on here. Before I introduce our guest this time, just a reminder, this is a live stream. We just don't want people to assume that this is some kind of crisis hotline or a way to get some crisis help. If you're really struggling, make sure you dial 988 or go to 988lifeline.org. And I always think finding a provider who can help you with your specific case is most important. So please make sure to check out the Find Help option on the website. That's actually how I found my therapist many years ago. So it's a really, really helpful service, and we hope that you're there. Welcome to everybody watching from all over the globe. We are international. I always see people from all over, and we'll shout them out in a second. But we are live here on Facebook, on LinkedIn, YouTube, Twitch, X, as well as IOCDF Lifeline, IOCDF.com / rather live streams. So beautiful to see all you lovely people. All right. Well, I can't do this alone. I always like having a guest, so I don't have to talk to myself. Real quick, if you're watching us on YouTube, make sure to like or heart and follow us, subscribe. That way you get notifications every time we have a live stream. I'm not the only live stream, so you want to make sure you get all those different live streams in your inbox. And if you're on Facebook, make sure you like or heart this video, as well as follow IOCDF's Facebook account. All right. So my lovely guest today is Dr. Jennifer Siegel, who is a board certified psychiatrist practicing in my home area of Southern California. It's always nice because then you know what it's like to have to rush in the morning and make calls and emails and meetings and then jump on. All the East Coast people always look relaxed because it's lunchtime for them.
Yeah.
Jealous. She earned her medical degree from the University of Pennsylvania Perelman School of Medicine after graduating summa cum laude from Washington University in St. Louis, where she received her bachelor's degree in psychology with a minors in graphic design and studio art. Ooh, fascinating. She completed her psychiatry residency training at the University of Southern California, shout out to USC, where she served as chief resident of outpatient psychiatry. Currently, Dr. Siegel specializes in medication management and therapy for OCD-related disorders, and anxiety spectrum disorders. She sees clients through her private practice as well as at the OCD anxiety focused IOP and PHP programs. So welcome, Jen. It's so good to see you.
Thanks so much for having me. It's nice to see you again too.
Yeah, you're amazing. And I was like, I sometimes I get in a fog and I'm like, oh, who I haven't asked in a while. I always feel like I'm bothering people. And then I was like, oh my God, I haven't had Jennifer on for a while. It's like she's so great. So
Oh, thank you
um
so much.
yeah, so good to have you. So
Yeah.
before I jump in, we have people from all over right now. We have Georgia in the house. It's always good to see Nathan. We have Europe in the house, Slovenia. I know. I always love that. We have Ash. Happy Wednesday. And Ash has pizza in their name. So every time I'm like, it's morning. So I'm not like quite hungry for pizza, except there's this breakfast place that has breakfast pizza and I
Oh,
need to try it. It looks so good. So Ash always makes me hungry. Hello, Spence. It's good to see everyone from Texas. Um, yeah, home ownership, you get to paint. I can't. So when you rent, you're kind of beholden, except Allegra is renting and she was asking, she was like, hey, I want to paint. And they let him. My place is like a complex and they're serious. Shout out from Twitch. It's good to see you. It's good to see everyone. We have New York in the house. Yes, we hope we're having a good day. So awesome. Ash, I see your question. We're going to jump into those shortly. Once again, this live stream is your live stream. So please ask questions. That's why we have a psychiatrist on. If there's any specific questions about medications or other interventions, I'm a licensed therapist that specializes in OCD and related disorders. I know Jennifer also sees people with OCD. So you can absolutely ask either of us questions about OCD as well. But remember, this is your live stream. Comment, interact with everybody in the chat, and it's good to see everybody today. But I always like to kind of start off with some questions that I hear a lot from the community, and both from people just starting out and more kind of advanced questions. So what I wanted to start with is when a patient first walks in. I think one of the questions I get asked a lot is, parents and stuff are putting their loved ones on medication, or somebody's going on medication themselves, and they're kind of like, hey, like, what should I expect? How are they going to know which medication? Is it kind of just like a guessing game? What is the process like? So let's say somebody watching this, and I'll ask an advanced question for people who are already on medications and stuff like that, but how, like, somebody sits across from you, how do you know they should go on medication and this is the kind of medication they should go on? What's kind of like the process in psychiatry currently for OCD and related disorders?
Yeah, that's a great question. So I think the first thing I always like to do is sort of just get a sense of where someone's at, because I know some of the times it's someone that's, like you said, very new to medication, first time seeing a psychiatrist, and oftentimes individuals who have OCD or anxiety naturally will have anxiety around medication, seeing a psychiatrist. So I always want to recognize that from the start. And sometimes people are there because they had an interest and sought it out, but sometimes they're there because others recommended it, and they're more anxious to be there. So I always like to kind of start with where someone at, and sort of meet them where they're at. But more generally, one could expect, a really thorough look through their, current symptoms, their past symptoms, how the symptoms that they're having are affecting their life more generally, and things like school, work, relationships, and really kind of just do a thorough review of any psychiatric history that they've experienced. And I think the other thing that is important to be aware of too is that as psychiatrists, we also do, a pretty thorough medical history too. And so, we'll ask things about medical diagnoses that you have. We'll be interested if, depending on the case, if you had blood work done recently, or talk about maybe that being something that could be of benefit. We'll like to know about family medical history, and all these questions kind of help us guide, if are there any medical factors that could be influencing the presentation that we can also address, or, if things come up from a medical perspective, it might make certain medications, more or less favorable. And so while there's a lot of different medications to choose, trying to get all of this history really help sort of narrow down what medications might be best for that individual person. And then the pace of adjusting those medications, really is person dependent as well. Yeah.
Yeah. And how long can people expect medications before they work? Because some people will say, oh, I felt like a change in a couple weeks. Some people are like, oh, I didn't feel a change until after about 3 months. Like, what do you see as kind of the average that people start to see some kind of shift, helpful shift?
Yeah, that's one of the hardest things, because a lot of the best medications we have for OCD take time to work. And so it's not to say that individuals can't feel any benefit in, the first couple of weeks, but really it takes, on average about 8 weeks, and then in OCD sometimes we say even up to 12 weeks to see the full benefit at any given dose. So I like to say that if someone is starting to notice a benefit as early as 2 or 3 weeks, then that's a great sign. And I think that, things will just continue to get better with more and more weeks. But the patience with that can be really tough. And that's one of the hardest parts about starting medication.
Yeah.
Yeah.
Let's talk about, for people that have already been taking medication, like let's say somebody's coming into your office, they're working with you and they've tried different medications. Let's say they tried Prozac and Celexa and Luvox, right? I know for me, like as a therapist, right? Like if someone's tried ERP and it hasn't worked, like I have other adjunctive treatments, I have other treatments. I like to, what I kind of call it is I look for the Achilles heel, like what isn't working? Like what is the conversation that we have to have in this room? And sometimes, there's family enmeshment. Sometimes the person isn't good at being consistent, or they need a high level of care. How for you, it's like if they've tried, let's say those 3 medications, like how do you know, hey, maybe this 4th one would work? Maybe we should try this one, an off-label medication isn't good. Let's look at TMS. Like, how do you kind of make that decision if somebody's tried some and just hasn't seen relief?
Yeah, that's a great question. And I feel like I often see individuals who have, both either are very new to medication or have had these more complex experiences with multiple trials. The first thing I always like to do is really review those medications. And I like to know what dose were they at, how long did they do the trial for? Because sometimes, and unfortunately more often than not, what I see is that individuals might be getting some sort of response, but not a full response on certain medications, like you mentioned, but they're not on the dose that's necessarily appropriate for OCD. So, sometimes, for example, with Zoloft, if we're treating more generalized anxiety disorder or depression, maybe 50 milligrams, 100 milligrams, even 150 milligrams might be a good dose for someone. But we know in OCD, sometimes it's evidence-based to go sometimes on Zoloft all the way up to 400 milligrams. And so, not to say that everyone needs that high of a dose, but the first thing I look at is making sure that they've had evidence-based medication trials, both in terms of the dosing and in terms of the length of trials, because sometimes I see people have been on things for a few weeks or not at the high enough dose. So those are the first things I always check. And unfortunately, I find that more often than not, sometimes people have been on a lot of medications, but not necessarily the evidence-based ones for OCD at those doses. And then after that, we really talk about there are a number of different adjunct medications that we can try. Once someone, I think, has had a good trial of 2 to 3 SSRIs at a good dose for OCD, we can consider adjunct medications like Abilify or Risperdal. There are a few other ones as well. There's alternate medications like clomipramine. There's pros and cons of that medication. But once someone's gone through a number of different medications and a number of different adjuncts, and they're also engaged in therapy, then we might start thinking about things like neuromodulation, TMS, like you mentioned as well.
Yeah. I was going to ask a different question, but there's 2 questions that popped up about the same topic, which was going to be my follow-up question to my next question. So I'm going to just skip to this question. Yeah. So we got a couple questions and I was going to ask the same. So obviously there's a question from YouTube. They're asking, like, is there long-term side effects for being on these meds for an extended period of time? We also have somebody else. We have somebody else who said, look, I've been on Celexa for 6 years. It's going to make me sick being on a long time. When you think about prescribing these SSRIs, are these medications that have shown to have a lot of like permanent side effects? People should not be on it very quick. For a very long time? Are they medications that are okay to be on for a longer period of time? What does the science tell us now?
Yeah. So these medications in general are very safe. Of course, everyone, there's individual reasons for certain people that maybe it's not as good a fit, and always talk to your provider. But in general, a lot of individuals are on these medications for a very long period of time, multiple years. And, for someone, if it's their very first time trying the medication, we might say, let's give it a year. And then if they really want to come off, we can sort of reassess. But for someone that's had multiple kind of, moderate to severe OCD symptoms at various points in their life, it often is recommended that this medication is more long-term. What I'd say is, there is some data that, maybe things like osteoporosis with, many years might be something to kind of just monitor and pay attention to. Sometimes like sexual dysfunction can be something that comes up for certain people, and there's ways to sort of address that as well. But I always like to say that there's risk of being on the medication long term, and that risk is relatively small compared to the risk of coming off of medication when you really need it. So that risk benefit discussion is really important. And what we do know is that if someone has significant anxiety and it's untreated from a medication perspective and it's more chronic, long term there can be a lot of complications leading to things like higher blood pressure, higher cortisol levels, risk of different metabolic issues or high blood sugar. And so if there is someone that has anxiety more chronically, it's not that there's choice either way, and there's risks and benefits either way. So just as much as maybe, being on medication, there could be some long-term side effects, we also have to consider, not being on medication and what those side effects per se might look like for someone.
Yeah, I know for me, I was very, very hesitant to go on medication. The reason I went on is about after 6 months of my treatment, I really, really struggled to get on medication. I struggled to make progress, and I talked to my therapist about getting on medication, and she was just saying, look, Chris, like you've put in so much hard work, you've made a lot of progress in those 6 months, but we're just hitting more difficult things, and your anxiety gets so high, you're not really learning any of the concepts because you're in panic during, kind of facing some of your difficult moments and starting to challenge these thoughts and get your lifestyle different. And I remember it's funny because I know there's a lot, I get it, right? Like I had a lot of health fears and I came with a bunch of questions. One of my subtypes is health related OCD. So coming in with a lot of questions, but what I found is what you just said is like, I noticed my sleep got better. My blood pressure went down. I was more relaxed. I was able to focus. I was more calm. And I'm like, oh, I don't know what the long-term effects are. We have a lot of good research on Prozac. It's been around since the late 70s. I'm like, I think I have some real health stuff going on, not being on the meds with chronic OCD versus that. So I know it's a challenge. I think about the people that could use it and are afraid. People, overthink on OCD, and people are afraid to go on meds. But, untreated OCD has its own really serious health risks too.
Yeah. And I really, appreciate that point too, because it's that makes me think of a few other, examples and things of, it's not just, the high blood pressure and sort of chronic anxiety, but depending on what one subtype is, it might, if it's, not well controlled, it can really lead to physical issues. Like, for example, if someone has more contamination based OCD and, they're having a hard time understandably using the restroom in public spaces, and then they're, not going to the bathroom when they need to. And then when that happens long term, maybe there ends up being, a consequence to their GI system. And now they're, seeing GI doctors to assess and help with that too. So the OCD and the medical can be really interrelated, and treating the OCD from a mental health standpoint can also, help with associated physical conditions that might result from that, like you mentioned.
Yeah. I want to put this one up there because I can definitely relate, Spence. Mine's a little different, but because of BDD, I have both OCD and BDD, and I was very anxious about sweating because part of my BDD was fixated on my skin, and I was afraid to sweat to get acne. And when I went on Cymbalta, more for depression, I went on Cymbalta, like I'd gotten better, and then I fell into a depression because it was like, oh my God, almost 10 years of my life was lost to these disorders. And Cymbalta did make me more shiny and sweat more. But what I did instead of jumping off, and this is what I try to tell clients to talk to you guys about, is like my psychiatrist and I talked about it, and we came up with some strategies. And it's like I used a little bit more deodorant, and I talk to my dermatologist, and she gave me these wipes that help like, retain oil, and it kind of like reversed a little bit or dampened it. I was able to get off the medication because I ended up doing well on it, along with some behavioral activation strategies. But I tell people, like, give it a little bit, like, and see if there's other things. If it's a side effect you just can't handle, obviously talk to your psychiatrist. But sometimes there's things you can do to kind of like combat the side effects that come up.
Yeah.
How do you know it's time for TMS? How do you know it's time for deep brain stimulation? How do you know it's time for supplements or self-care over medication? Like, when have you gotten to a point where you're like, hey, I really think this client needs to benefit from some other intervention that science has?
Yeah. So I would say that, once someone has done a number of both medication trials at, again, like OCD, dosing, duration, and has been in, the appropriate ERP therapy. And that includes, maybe not the outpatient, maybe they need to be in an IOP or a PHP or even a residential. And if they've tried like different higher levels of care in combination with trying, maybe at least 3 different types of, SSRIs, and then they've also kind of gone through the adjuncts, then I definitely start talking about TMS. And, in fact, I'm pretty sure, TMS and some of these other neuromodulation techniques require that you've at least tried a number of SSRIs before being able to have that approved as well. So it kind of depends on the person, but yeah, I would say I just want to make sure that they've had, a thorough trial of both the medication and the gold standard therapy component too. Because unfortunately, sometimes I'm sure you see it too, Chris. Sometimes, a lot of people have been in treatment for a long time, but they might not be getting ERP specifically in terms of therapy, or they, might, not be have given SSRIs specifically for OCD. So.
Yeah, no, and that's I see a bunch of questions popping up, so I want to jump into those. But that was kind of a question I had for you, though, is you kind of brought it up, is like, how do you see the medication and the treatment working together? I'll kind of give you my perspective after you give yours, like on the therapist side. But for you, is like, how do you see those two working in adjunct?
Yeah. They can be really beneficial working together. Similar to the story that you briefly shared earlier. I mean, so, of course, with ERP, we know it's anxiety inducing, and it's intentionally anxiety inducing, and we want people to feel anxious when they're doing ERP. But sometimes, we're just not at a place where we can start the ERP because the anxiety is too high. There's too much panic. And so sometimes starting a medication can sometimes take a little bit of that edge off to be able to more effectively engage in the therapy. And still, you'll still be anxious. It's not going to eliminate all the anxiety, but it kind of helps someone sort of get to the place where they're maybe more ready to do ERP, because it can sound really overwhelming at first. And then, with time, once someone has been doing ERP for a long period of time, they're building a lot of skills, they're building a lot of tools, they're becoming much more comfortable tolerating uncertainty and tolerating the discomfort that they might be able, if they are someone that's interested in coming off of medication, and it's, one of the first times they've sort of experienced that, and they're a good candidate to try that. I think having had the therapy might also allow them to sort of more easily taper off of a medication too.
Yeah.
Yeah.
And then lastly, before we jump in questions, anything exciting in the well, I want to give my perspective, and then I'll ask that question. No, I mean, I think for me is like, I always tell my clients I'm not a medications pusher, because I don't, that's not what I specialize in. I'm not a psychiatrist. But I know for me, like when I see a client where it's just they are bombarded with obsessions throughout the day, they really struggle to disconnect, and that obsession kind of talk becomes a mental compulsion, whether it's mental review or neutralizing a thought, counting to distract, or just traditional like kind of rumination. If they're anxious to try anything they push through, what I've always seen with medication is some clarity in thought. Like they start almost talking a little bit more logical and recognize like, hey, I don't think all of these things are necessary. I see sort of like a calm and a peace start to come in, and they're a lot more relaxed. I don't know if you could hear that, but that means that my washer is done. I forgot to turn it off. I just see sort of like that kind of like focus, that calm. I noticed that they're able to do more treatment and exposures and engage. And so for me, I always can tell if a client needs medication, that medication has been effective because they just seem to be more locked in. They can be more consistent. They're able to do the work and they see the benefits from it. It doesn't feel like this constant fight and like, I'm making myself miserable. It's like, yeah, I kind of get dysregulated, but the thing I'm focusing is so amazing and so like important for me to go to my nephew's, graduation despite the thoughts, or going back to church despite the thoughts. Like there's an easier like and a willingness that I see with medication.
Yeah, definitely agree with that. Yeah.
Ash calls me out. I always try to like, I'm always doing like 5 things at once to make the most of a day. And so I like threw in some laundry before.
I was worried it was a fire alarm for a second.
No, it wasn't my washer, it's my dryer. And I was supposed to, I hate that noise and I thought I turned it off. But okay, let's jump into some questions. We got a lot of good one.
Yeah.
I like this question. What are kind of the frontline SSRIs for OCD? And then do comorbidities come into play? Like if somebody has co-occurring ADHD, or let's say co-occurring depression, or ASD, autism spectrum, does that come into play, or does that not really matter nor factor in this situation?
Yeah, it really depends on the person. And I see like the specific question is like the first SSRI you recommend for OCD. And what I will say is, I know some of the SSRIs are technically FDA approved and some of them aren't, but they're all evidence-based for OCD. In thinking of just, starting kind of more broadly with someone who doesn't have comorbidities and it's kind of just the OCD, picking the SSRI is really tailored to the individual person. What I like to say is just because something is an SSRI, like Zoloft, Prozac, Lexapro, Luvox, whichever one, they all target different receptors a little bit differently, and they all have slightly different side effect profiles. So sometimes, depending on like the specific experiences someone is having, it might make me lean a little bit more towards one SSRI over the other. So for example, if someone has really bad OCD and it's really impacting their sleep, they just cannot fall asleep at night, I might consider something more along the lines of Paxil, for example. It's like or Luvox, which are both a little bit more sedating and often recommended to take at night. So it's sort of helping with maybe the insomnia piece as well as the OCD. Whereas someone who, might also lean a little bit more depressed with their OCD, I might think of trying something like Prozac first, just because that one does tend to hit a little bit more of the dopamine receptors, and the other one then kind of can give a little bit more of that activation. And so there are some nuances a little bit between the SSRIs. And then also thinking, again, that's where the medical piece comes in too, because sometimes SSRIs can have interactions with other medications, like someone is on a statin or something along those lines. And so not all SSRIs may interact with that one. So that kind of can help me pick, if someone has a certain medical condition, like a heart arrhythmia, I might lean away from something like Celexa, for example, just because that one might, at higher doses, might be a little bit more risky for someone who has that. So it really is like something, not all SSRIs are created equal, and they're all not equal for different people. So I think that's the first thing. And then, if there are certain comorbidities, like I mentioned, like depression is of course a common one, kind of thinking through, those nuances between the two. I think you might've asked about a few other different things, but ADHD, I think you mentioned. Yeah. I mean, sometimes people are also on, it depends, like more than one medication. I think something to keep in mind with ADHD that can be somewhat tricky at times is that, a lot of the first line medications for ADHD, like stimulants, can be very anxiety inducing for someone who has OCD or anxiety, because that stimulant effect is very activating. And so I often find sometimes people do well with some of the non-stimulant options for ADHD. Or even, really kind of taking a step back and nailing down the diagnosis too, because sometimes I see individuals misdiagnosed with ADHD when it's OCD, or kind of vice versa. So yeah, I think those are some of the initial things that I look at.
Yeah,
Yeah.
well said. Um, we didn't talk about benzodiazepines, so the question is, the one that worries me is having to come off Klonopin. Oh, they asked the first part. Sorry, they said I was fortunate to try Paxil, which made my OCD worse. Then we tried Celexa and Klonopin. This has helped me 25 years after being diagnosed. The one that worries to come off of is the Klonopin, but I don't want to rock the boat. So I wanted to ask you that question. I was talking to a psychiatrist yesterday, a client I'm about to see. They're seeing right now, and they're like, "Hey, I just want to give you a heads up. Like, I did put them on a benzodiazepine. I think their anxiety right now is so intense that they won't be able to properly execute ERP and really face it. They have the want, the desire. They want to get better. We're obviously going to talk about coming off of the benzodiazepine when appropriate, but they need this. So what's kind of the field's thoughts on things like Klonopin? How do people go off it, like this question, without rocking the boat? Like, what's sort of like the mindset around this?
Yeah, those are really good questions, and it can be tricky. And I know Carissa asked this question, so again, this is going to be more broad and not specifically about what you should do or not. But yeah, like you said, sometimes the anxiety is so high, and sometimes we often like to try non-benzodiazepine as needed medications first, like things like hydroxyzine or gabapentin or propranolol, but sometimes that just doesn't cut it, and we need to think about things in terms of a benzodiazepine. My approach is typically, if I'm starting a benzodiazepine with someone, the goal is hopefully and made up front that this is really more of like a short term, like maybe 6 weeks kind of thing to help you adjust to the other medications and therapy and things that you might also be engaged in, and trying to frame it up at that way up front, because there are long-term risks to being on benzodiazepines. And so but at the same time, for different people, sometimes it can be really tricky to come off and really hard to come off. And sometimes I know the way of thinking has shifted in the field. So, a number of years ago, benzos were very commonly prescribed, and now not so much. And now they're much more of a bridge treatment rather than long-term use. But that's kind of how we tend to approach it. And then in terms of coming off of the benzo, it can be scary, of course, if someone's been on it for such a long time. And I think it's really important to be really gentle with the process of coming off of it at that point, if it's something that you and your doctor decide would be, beneficial. It's, a lot of the times if someone is being prescribed like shorter acting benzos, like Xanax or Ativan, we often end up switching to Klonopin to help, because it has a little bit of a longer half-life, so it's easier to kind of come off of something like Klonopin than some of the shorter acting benzos. But yeah, it's a really gradual process, and tapering, sometimes, I always like to set the expectation that if we're tapering something that you've been on for a long time, this could be many, many months or a year of tapering. It's not something that like we have to do over a week or two, and it might not even be possible over a couple of weeks. So I think sort of setting the expectation up front is important, and just being really gradual with it. Yeah.
Yeah, well said. Yeah, I find that I'm seeing that more and more. Like, if I have a client that's been on it long term, like going off of it. But like, I think people always want to do is talk to your psychiatrist. Nothing should be like immediate, right? It can be done, in steps, so it's not overwhelming. How about, what medication do you recommend for people with bipolar disorder and OCD? Is there have to be special kind of cautions if somebody has bipolar disorder when prescribing OCD medications?
Yeah, that's a really great question, because as we know, with a lot of the OCD medications, they're in this drug class called antidepressants, and so they're also used for individuals with depression. And one of the things we worry about, if someone's had like a manic episode in the past, if someone is on something like an SSRI or some sort of antidepressant, the concern would be that it flips them into mania, and of course we don't want that. So that's not to say that you cannot be on an SSRI if you have bipolar or had a history of mania. It just means that it involves a lot closer monitoring and oftentimes also being on a mood stabilizer at the same time. Again, it depends, specifically on the person, but I find that, Lamictal can be something that's really helpful as a mood stabilizer. And once that's in someone's system, they're maybe better able to tolerate something like an SSRI without flipping into mania. Again, it's person dependent, but yeah, I think that I would say those are the main things we want to worry about, and then also like very close monitoring of that as well. And Lamictal, it's not considered, it is used as an adjunct for OCD as well with SSRIs. It's not necessarily, at the top like something like Abilify would be as an adjunct, but it is considered. There's some research that it can be a good adjunct. So yeah, that's usually my approach, is getting someone stabilized on a mood stabilizer first and then sort of adding on some of the medications for OCD.
Said. This was a pre-submitted question. I have a bunch of those too. And I'm going to go back to live questions because we have a bunch of those. Somebody's saying, I'm currently taking 10 milligrams of these names, man, y'all need to come up with some prettier names. Acetalopram since 1 year. My doctor isn't letting me increase it. According to PubMed, it says 40 milligrams. Okay. What's your opinion? I wanted to ask this like in general, right? One thing I do hear from clients a lot is I had a client who has severe OCD and was on 20 milligrams of Prozac for 4 years. And it's like, I'm not a psychiatrist, but I know enough and done enough trainings and research to know that's a very low dose, especially for OCD. How do people have that conversation? Like, I don't know with this medication specifically, but maybe answer this, but in general, like, how do people have that conversation with their psychiatrist if they really truly are feeling like they're on too low of a dose?
Yeah, that's another thing that I see a lot as well. And it kind of goes back to the beginning of when you were asking about someone who's been on so many medication trials. And that's kind of the thing, is sometimes people have been, and it's been on those doses, like you mentioned, of Prozac 20 milligrams. And it can be really frustrating, I think, when someone hears that, okay, I've been on this for so long, but I haven't been going up to the dose that would be beneficial. But yeah, so I do feel, for some individuals that are maybe not psychiatrists, primary care providers are, I think, like the number one prescribers of these antidepressants, just because, access to a psychiatrist can be limited at times. And so, primary care doctors are amazing, but they don't have as much specialized training. And so sometimes I see that it can be a little bit more nerve-wracking for them to go to higher doses, especially ones that are higher than the FDA approved dose, even though they are evidence-based for OCD. But, what I will say is, I think in this specific question, I think that was maybe escitalopram or Lexapro, 10 milligrams. And that's, yeah, I mean, I would definitely bring that up, because even for Lexapro, 20 milligrams is considered within, the FDA approval. And yes, for OCD, sometimes we do go up to 30 or 40. Of course, there might be something else, another reason that the doctor is hesitant to go above that, based on like specific medical history or something like that. But yeah, I mean, it can be tough, right? Kind of coming to the doctor and sharing, hopefully, the way I like to approach things is just be very open to, and if sometimes, I have patients or clients that have seen a new research article or have seen something and they share it with me, and I'm always very grateful to learn and see more things. So, but I know that can feel uncomfortable sometimes. But yeah, if you're going to your primary care doctor and they're, nervous to go up, maybe asking for a referral to see a psychiatrist, or if you are seeing a psychiatrist and they're more of a general psychiatrist, maybe asking if they have referrals to someone who specializes in OCD, or if there's someone they can consult with or something along those lines too. Yeah.
Thanks. I know a lot more people are reading about, obviously, inflammation in the gut and anti-inflammatory. So is there any anti-inflammatory type drugs in the pipeline? And is that highly associated, or do we feel like this is going to be something that can be helpful at all for people with OCD?
Yeah, to be honest, I'm not sure of specific. There might be some anti-inflammatory drugs specifically to OCD in the pipeline. I haven't heard specifically, but that doesn't mean that doesn't exist. But there are a lot. I think more recently there's been a lot more research just into so many other aspects and approaches to kind of seeing, the optimal treatment for OCD. So I know that doesn't specifically answer the question, but I think that there's probably, especially I'm thinking of like individuals who have OCD associated with PANDAS, for example, of different, immune disorders that cause inflammation and can be associated with OCD. I'm sure there is some sort of link there. I'm not as familiar with specific drugs in the pipeline, though. Yeah.
No worries. There's a question about, like I said, y'all need to name these prettier. Troriluzole.
I'm guessing based on the end of that medication that it is similar to Riluzole, which is a medication that is kind of consider that might be probably a newer version of Riluzole, based on the end of that. But yeah, there is some research, looking at Riluzole and some of these other medications. They're used more in like different neurologic disorders and psychiatric disorders presently. There's, some data that's kind of hit or miss. And again, when we're sort of getting into some of these, third, fourth line trials of meds at this point, when we're thinking about medications like that, just because there are so many other ones that are more evidence-based before getting to that point. But, just not to say that it doesn't work. It could work. I think there is research exploring it, for sure. But yeah, still waiting for more of the trials to kind of point in one direction or the other.
Thank you. How I like this question because how do you know when a prescriber is prescribing medications that they don't want, right? So sometimes I'll have clients see psychiatrists that aren't as well versed in OCD related disorders. And so they'll get an OCD SSRI, but maybe they'll also get an antipsychotic and benzodiazepine and maybe a blood, pressure medicine like propranolol, or they'll get, something. I had a client who, just mentioned in his intake form for getting medications for OCD that sometimes he has trouble sleeping because of intrusive thoughts, but he got a sleep medication and then it's been hard to get off of it. So how can people know if they're being over medicated? What should be some things they should ask? Like in this case, obviously, like they're on Celexa, it's helping them a lot, but they just got 3 new meds over 2 weeks prescribed. How do they know, what is needed and what's not?
Oh yeah. That's a big thing for like my soapbox is polypharmacy, and it's tough. And I don't think it's on, it should, well, at least it shouldn't be on the patient or client to know. It should be on the prescriber to know. But, sometimes things are added on. And so what I would say is, things to ask, your prescriber before kind of taking on a new prescription, if it feels like a lot, is, the first thing is there a way to optimize any of the medications I'm currently on first rather than adding another thing on? Or, is there a medication that could, target more than one thing rather than having multiple medications doing different things or different areas? Because some medications can do multiple things. Other things I might ask are, if I were to be prescribed another medication, is this something that's more of an as needed medication? Is this something that I should expect to be on more long-term, or is this something that might be more of a short-term medication? But in general, one thing that I think is always really important, unless it's, someone in an inpatient setting and maybe you don't have as much time to kind of navigate things. I always think it's important to just do one thing at a time, and, give it some time, just because, if you try something new and you have a positive reaction to it, then that's great. But if you're doing 2 things at the same time, how do you know which one gave you the positive reaction? And then you're nervous to stop both of them because you don't know which one it was. And then same thing for negative side effects. If you try multiple things at the same time, you don't know which one is giving you the negative side effect, and then you might be inclined to be off all of those, and then you've just eliminated a number of medications. So yeah, I think, always asking, like, is there a way I can try just one thing at once, and just, maybe asking like, what is the indication and difference between all of these medications?
Yeah. There was a question about prescribing two different medications, like 100 milligrams of Zoloft and 100 milligrams of clomipramine.
Yeah. So I guess with that specific regimen, I'd be curious, as to why those specifically, because it seems like neither the Zoloft or the clomipramine have been like optimized at like the maximal doses. Perhaps with clomipramine, even though you can go up to 250 milligrams, we often look at blood levels. So sometimes, 100 milligrams might be the max dose for someone. But just upon looking at that, I might wonder, why like the Zoloft hasn't been maximized before adding on something else and vice versa. So sometimes things can be used together, but usually, you want to try to maximize one of them first to, again, eliminate the polypharmacy between the two. And then again, with certain medications, like these two, these are both, serotonergic. And so if you always want to sort of weigh the risks and benefits, and you don't want to have something, like serotonin syndrome happening or things like that. Of course, if you're being monitored, then, it'll be safe with your provider. But I don't often see Zoloft and clomipramine together. Sometimes you'll see clomipramine and Luvox together, actually, but when we do that, we're usually using Luvox at a much lower dose, and we're not using Luvox as an SSRI specifically to treat the OCD. We're actually using Luvox in this kind of fancy, tricky way where Luvox and clomipramine interact with each other. So when you add a little bit of Luvox, like 25 milligrams of Luvox to clomipramine, it can actually help, it adjusts the metabolism of the clomipramine and can make some of the side effects a little bit more tolerated. But otherwise, yeah, I would want to optimize one medication before kind of adding another similar medication at the same time.
I wanted to ask this question because this is something I always wonder as a clinician. Basically, the question that they're asking is like they're on a medication, Cymbalta. They're afraid to raise it because of side effects. Is that always the case? Because the reason I always ask is because I know for me on Prozac, when I started on Prozac, I was having a little bit of sexual side effects and tiredness. I was sleepy, but as I progressed up to, I ended up going on 80 milligrams. The side effects went away and I felt fine. I actually felt better on higher dose and no side effects. Is that always correlated? Like somebody's doing great on a med, and if they go up, they're going to for sure get side effects? Or is that just something we worry about as people with OCD?
Yeah. Those are good questions. It's actually interesting because, what I find is that, I mean, anytime you go up on the dose, it's of course possible to have, some side effects. And if that happens, usually, it doesn't last more than a few days or a week, and it settles out pretty quickly. But in general, it is individual. I would say it's more likely to have side effects when you're making a jump at lower doses than higher doses. I know that can sort of initially sound counterintuitive, but the way I like to think about it is, if you're starting a medication, like Zoloft, going from 0 milligrams to 50 milligrams is very different than going from 150 milligrams to 200 milligrams. Yes, they're both 50 milligram increases, but they're different on your body because, when you're going from 0 to 50, you're going from no Zoloft in your system to all of a sudden having a lot of Zoloft in your system. And that's a big difference on your body. By the time you get up to something like 150 milligrams, the majority of your serotonin receptors are already occupied by the Zoloft. So adding another 50 milligrams to your body isn't necessarily going to occupy suddenly so many more serotonin receptors and cause those side effects. So the difference to you at lower doses each time you go up is a bigger percentage of occupying receptors than when you're at higher doses and things are already very occupied, if that makes sense.
No, it does make sense to me.
Yeah.
No,
Yeah.
it makes sense, right? Like it's already, I do everything in analogy. So I'm thinking about it, like, if you have your own house and you're living by yourself, you're comfortable with that. And as family members come to stay the weekend, maybe because there was like a power outage for their hotel and they start staying at your place, like at first it's jolting. You're like, oh, I haven't had people stay at my place before. Now suddenly all these people and I'm trying to find them beds. But once you have like, 10 people there, if two more come, you're not like, oh no, what do I do? It's like you're beyond that, right? So that
Yeah,
was my
yeah.
analogy that
I
popped
love
up.
that analogy. I'm gonna steal that and use that from now on. But
Yeah,
yes,
you're
it's a
kind of just
perfect
like, well,
analogy.
at that fact, like I already
Yeah.
know the hotels are down. I know family is coming. Like I've already gotten used to it. We've already done the Costco run to have the food, right? But no, it makes more sense because I always hear that for clients and I never feel like I have a good answer. So when I saw your question, thank you, Yuri, on YouTube, I was like, yeah, I wondered that because I had the complete opposite. It was like once I got on a higher dose and I was on it for a while, like all the side effects melted away. It was more jolting at the start. So I have clients that are always afraid if they've had some side effects to go up. And it's like, it makes sense. If there's already that Zoloft on the receptors, adding a little bit more isn't going to be a drastic jolt versus going from nothing to something.
Yeah, yeah. I love that analogy. Just like you said, like if you're by yourself and you have two friends come over, that feels very different than being by yourself. But if you're have 10 guests over and another two come over, not a big deal.
I
And
also think about weddings because it's like when my
yeah,
sister was getting married, it's like, at the end, if somebody is like, oh my God, my cousin's in town, can I bring him? You're like, well, I've already spent my life savings on this dang wedding anyways. But in the beginning, you're so particular.
yeah.
Like, no, I don't care that your mom is on their deathbed. Like the food is $150. I can't invite them. Right. So.
Yeah. The one caveat I will say to that analogy, I would say in general that is true, especially with things like SSRIs. Certain medications, like if you make as you go very high, like you are hitting a little bit different receptors, so it's different. So for example, I'm thinking like trazodone, we use it as a sleep aid all the time at like 25 milligrams. And at those lower doses, it's more of an antihistamine effect. But if you were to give someone 300 milligrams, which we don't really often do, but it is technically an antidepressant at that dose, then you're starting to hit a lot different receptors than just antihistamine. So that's the one caveat of like certain medications, maybe you're hitting a little bit of a different receptor as you go up. But things like SSRIs are generally what I found exactly like the analogy that we were talking about.
Awesome. I like this comment from Meredith. A lot of times I have clients say ERP didn't work for me. And when we really talk about it, I think the reason I like this is like, I'll have a client because I do a higher level of care. I do a one-on-one IOP, and I'll have clients come and say, ERP didn't work for me. I don't know if it's going to work in a higher level of care. And there's somebody who's taking 4-hour showers. They struggle to use the restroom. They haven't been eating. They're not seeing their family. They're isolating. And I'm like, I don't think you're at a place that ERP alone, you need medication, right? Like it's struggling to brush your teeth, to do those daily activities.
Yeah.
So a lot of times it's not that the medication, it's not that the ERP doesn't work. It's just that somebody's so severe, medication would be helpful.
Yeah, definitely agree with that. Yeah.
Is there any new meds in the pipeline? Anything exciting? Or I know they
Yeah.
take so dang long.
Yeah, I think, some of the things I think about are they're like newer meds that have come out that have gotten approvals for certain things, and we're still sort of waiting for trials for things like OCD. Things that come to mind are like Trintellix or Vilazodone, which are the newer serotonin, modulators, not technically SSRIs. Those are already out and are used in depression and anxiety, but and sometimes people are even trying them for OCD, but there just haven't necessarily been the trials yet to know if that is something that is effective or not. So yeah, I've kind of been interested in some of the medications that are newer, but haven't necessarily gotten to the OCD perspective yet. And I think another thing that people are considering are not necessarily newer medications, but using medications that already exist for other purposes and seeing if they're effective for OCD. I think there's a lot of talk about different glutamate modulators and things along those lines. If those can be, we might use them more in things like Alzheimer's or other things, and maybe they might be beneficial in OCD. So, yeah.
SSRI induced apathy or lack of motivation that is not depression related. Do you see that happen commonly in SSRIs?
I guess what I would ask is, which, it's possible that maybe that specific SSRI isn't the best fit for that person. And I might be curious, which SSRI that is. As I mentioned, some of them can lean a little bit more sedating and some of them can lean a little bit more activating. So perhaps if they had been put on one of the ones that was a little bit more sedating, they might be experiencing sort of that sort of induced apathy, lack of motivation. But typically we're trying to treat that with the SSRI. So if that's something that one is noticing, then it might be a question of asking their provider if there's something that might be a better fit.
Yeah,
Yeah.
I know for me, I took Prozac for my treatment and I stayed on 80. And when I was better from OCD and I was like going back to work and living my life, I did start to feel some of that numbness. And what my
Mhm.
psychiatrist said is like, hey, we were hitting you with 80 when you were like non-functional, housebound. Now
Yeah.
you're working, you're living your best life. And so we went down. And then I found that at 40, it was perfect to still help me with anxiety and OCD.
Yeah.
It just felt like maybe it was giving me too much, and I think it was like I didn't have enough going on in my life
Yeah,
anymore
yeah.
to
I mean,
combat it.
yeah, that's another great point too is and sometimes I always ask, I know there's a fear of like this blunting, which I mean maybe is kind of what was meant, but the induced apathy. And sometimes what I like to ask people is, for someone that has had severe anxiety and OCD for so long, they're used to being in constant fight or flight mode. They're used to being like on edge all the time. And if the SSRI is working and they're not feeling that, then, you know, is that I always like to wonder, and I mean, it's different for different people, but like, is that what the sensation feels like to not be on edge all the time? And or is that or is that apathy, but it's just kind of yeah, it is a very different baseline of not being in fight or flight can feel very different, and relatively speaking it often can feel more like a blunting, because it is a blunting of that, but we just want to make sure it's not like below a baseline that we would hope for, but
No, that's a good point too. If you're so used to being on edge all the time, normal life starts to feel a little bit boring. I felt that too, but once I transitioned into life and went back to school and dating and friends and stuff, then I
yeah,
was like, "Oh no, this is just healthy." I was just
yeah,
always stuck at fight or flight.
yeah, yeah, exactly.
Is any of the medications, if somebody has MS, I always forget what it stands for. I always is
Multiple
multiple
sclerosis.
sclerosis, yeah.
Yeah.
Is there any kind of cautions people have to take with OCD medicine, or can they pretty much kind of just go for it?
Yeah, I mean that's a great question. I would say, one thing to think about is I always like if someone has, a chronic illness or something that is definitely impacting them, to always collaborate with their neurologist or cardiologist or whoever it may be, neurologist in this case. Because sometimes what we find is that a lot of the treatments for these autoimmune diseases are very, very important, but they have psychiatric side effects. And so, and you have to be on these medications to manage things like MS. And so the first thing I always like to do is just kind of get a sense of like, did some of these symptoms first start, following, certain medications for the MS, or were they more predating? And then of course, also just having an inflammation in the body with or without the medication for it can also induce the anxiety. So oftentimes these things can be comorbid, but in general, I wouldn't say there's a specific one to kind of lean into or avoid. But it's always sort of like an individual case by case basis.
I'm gonna try to squeeze like one or two more in.
Yeah.
Somebody asked, I've had OCD for quite a time. Is been on Luvox and was recommend buspirone for very stressful times. How about using those two together?
So, I know a lot of people have mixed opinions on buspirone. What I would say is that, um, you know, the first step that I would always sort of think about is like, is the Luvox optimized first before adding on buspirone? Because we do know that there's a lot more evidence based specifically for Luvox and OCD than buspirone. And sometimes what I see is people are added buspirone on an as needed basis, and or sometimes standing, but the doses that people tend to be on are things like 5 milligrams, 10 milligrams, 15 milligrams. And the research really shows that if it's going to have any impact in terms of anxiety, we're thinking more in the range of like 30 to 60 milligrams. And at those doses, there can be a lot of side effects. And especially if you're already on an SSRI, those two are both serotonergic. So people end up having things like tremors, et cetera, if they actually are on a dose that's more effective for anxiety on Buspar. So I don't tend to prescribe Buspar. I mean, I do see individuals come to me on Buspar, but it's not my first choice. I think there's a lot of other medications that are more effective, and yeah. So I would first kind of think about optimizing the Luvox or adding some other adjunct that's more evidence based for OCD.
All right, last two we're going to speed through. Is there anything with ADHD and autism? So ADHD, I don't know how to pronounce it, but when people have both ADHD and autism, is there something that people have to worry about when it comes to OCD medications, or does that typically not come into factor?
So if someone, like, kind of thinking about someone who has comorbid autism, ADHD, OCD, I mean, it really, again, I know this is kind of a hard thing, but it really depends on the individual person and their history. But, in general, there's a lot of individuals with ADHD, OCD, on these medications for OCD that I've kind of talked about and do really, really well. And then it's sort of, thinking about other components from a therapy perspective that might be helpful, both from an ERP lens, maybe a behavioral lens, and then, just kind of thinking about the other medications and being cautious with the stimulants, just because that can maybe exacerbate OCD or anxiety for some people.
Would they need a separate medication for depression if they're on Celexa, or does Celexa usually take care of it as well?
Yeah. So things like SSRIs, like Celexa, are indicated for both. So hopefully both. The Celexa should work for both. If it doesn't, then there are certain adjuncts that you can add on to Celexa that can help for both, like Abilify. But yeah, hopefully both.
And then finally, so I'm guessing. So I know a lot of times, like, people with ADHD, OCD, substance use. This person was on Adderall, but switched to Strattera for ADHD, I'm guessing, and then is on Viloxazine for OCD. I'll just talk about the substance use part, and then you can talk about the medicine part. A lot of people having intrusive thoughts all day, compelled to do compulsions for hours, watching their life slip by, are going to turn to maladaptive coping techniques like substance abuse. What we got to work on is giving your son different tools so that they can help regulate themselves and have some self-care that isn't through substance use, because that brings on a slew of new additional problems. You're kind of like knocking one problem down for a new one. So I used substances in high school because it was the only thing to numb my brain before I had a diagnosis and tools. Once I got that, I was able to stop drinking as a coping mechanism, because I really was able to focus more on these other coping medicines as well. But I do see that. And then with ADHD, it makes us more impulsive. And so sometimes, people are not thinking as thoroughly about how the substance use can impact. But it sounds like your son needs something. I'm hope that he's in therapy.
Yeah. And just to add on that, it sounds exactly right. And just to add on in terms of switching to Strattera, I mean, it is, it's not a stimulant medication, so it definitely doesn't feel as strong as Adderall does. There are other medications like guanfacine that are sometimes used, or Wellbutrin that are sometimes used, that are non-stimulants. And then Vilazodone, I think you're asking if that was good for OCD. That was one of the ones I was talking about earlier. That's a newer medication that has a lot of promise in anxiety and depression. And the research isn't necessarily there yet for OCD, but that doesn't mean it won't be effective. It's just a newer medication. So, yeah.
Someone just said, thank you. It was very helpful. So I always like to say nicely. So just kind of giving you final thoughts. How did that question pop up? Go away. I don't know where it came. There we go. Just final thoughts to take us out. Anything you'd like to leave the audience with? Something to any kind of final thought?
Yeah, I guess, what I would say is, sometimes I wish it wasn't always the case, but you are all your own best advocate. And so, if something feels a little bit off, or you're feeling like, there could be something else, and maybe that you're interested in seeing someone that is more focused on OCD or things like that, I would really check out the IOCDF website and provider list to find someone that might be a little bit more specialized for you too. Yeah.
I always think about it as like, a person who's working with you one-on-one can give you more specifics. So please, if you're watching this, look for help. My final thought is this Saturday at 11 a.m. I run a free family and loved one support group. It's like this. It's educational. It's not meant to provide treatment. But my mom and I have been running it now for over 13 years. And this Saturday, we're having a woman with OCD who's a mom and has 2 children with OCD, one with PANS and PANDAS. I know there was a question on that, and her daughter's newly diagnosed. So if you are a loved one, a supporter, a spouse, and want to find some support and some education, hit up info@ocdsocal.org and join us. I'll be back next Wednesday at 12 Eastern with Kimberly Quinlan for another Ask the Experts. I want to thank everybody that asked a question, and a huge thank you for everyone who engaged, but a bigger thank you to Jennifer Siegel. Dr. Siegel, thank you so much for lending your time, your expertise, and coming out today. You were so helpful. We'll definitely have you back, and I hope everyone finds this super helpful. And remember, this is not the only time people can watch it. They can go back to IOCDF's YouTube or Facebook and watch these back. Thank you so much, everyone, and have a great rest of your day.
Bye. Thanks for having me.
All right. Take care, everyone. Bye.